Thank you, Mr. Chairman. Good morning, everybody. I'd like to thank the organizers for allowing me to present this interesting case this morning. I would like to especially thank Rueda for accommodating me to present this morning, as I have another commitment this afternoon. Please excuse the brevity of this presentation, as there was a lot of information that needs to be condensed into this short presentation. The index patient is a 23-year-old female with a background history of having been diagnosed with polyarticular seropositive juvenile idiopathic arthritis at the age of 12. In December 2005 was the first time she presented to me. She was on triple therapy with methotrexate as being the anchor drug at the maximum dose, together with cilazoparin and chloroquine. When she presented, she had a fever of 1 month duration, and it was documented to be quotidian. She also had an evanescent skin rash and generalized lymphadenopathy. At the time she presented, she had a tender joint count of 8 and a swollen joint count of 10. She had markedly elevated inflammatory markers with a sedimentation rate of 54 millimeters per hour and a C-reactive protein of 36.6 milligrams per liter. We undertook a lymph node biopsy at that time, and it showed reactive lymphadenitis, and the diagnosis was then revised to systemic juvenile idiopathic arthritis. Her screen for tuberculosis was negative, and infliximab was then commenced in January 2006. She had a dramatic response to infliximab and remained well until the 17th of August 2009 on infliximab, cilazoparin, and methotrexate. On the 17th of August 2009, she presented with a fever. This time it was unremitting. She had headaches, which were non-specific, and left upper quadrant abdominal pain for the last 5 days. In view of the patient having a high pyrexia, she was admitted. She was pyrexial with a temperature of 39 degrees. She had no obvious signs of infection on clinical examination. She had no meningism, and there was no flare in her arthritis. On day 4 post-admission, she developed status epilepticus, which was unresponsive to usual anti-epileptics, and she required ventilation in ICU. In terms of investigations, an exhaustive search for an infective agent proved fruitless. She initially had a leukocytosis, which subsequently she then developed a bicytopenia. Blood cultures were negative. Urine cultures, throat swabs, and a chest X-ray was normal. The lumbar puncture done post-seizure showed a reactive cerebrospinal fluid, which showed no evidence of any infection. Her procalcitonin level was less than 0.5 nanograms per ml. Her sedimentation rate was 26. However, her C-reactive protein was 316. Urea and electrolytes were normal. An MRI of the brain undertaken was normal. An ultrasound showed a splenomegaly, although at the time the spleen was not palpable. She had a progressive drop in her hemoglobin over the next 2 weeks, and you can see she started off with a hemoglobin of 13.4, and by the 29th of August it dropped to 6.2. Her white cell count also dropped to 4.1 over the same period, as did her platelets. She had a marked elevation in her transaminases with the alanine transaminase of over 4 times upper limit of normal and an AST of about the same area. Her HIV screen was negative. Epstein-Barr virus was negative. Cytomegalovirus was negative. Hepatitis A, B, and C was negative. She had marked elevation in the ferritin levels. The D-dimer was positive, and she did have a coagulopathy. Her rheumatoid factor was positive, as was her anti-CCP antibodies. Her anti-nuclear factor was negative. Her MAN2 was negative. Quantiferon gold was negative, and her chest radiograph was completely normal. Any hypotheses with this patient had to explain her, Any hypotheses with this patient had to explain her fever, mental state with seizures, splenomegaly, cytopenias, elevated transaminases, her hypofibrinogenemia, coagulopathy, and her extreme elevation in terms of her ferritin. Thrombotic thrombocytopenic purpura must be considered in this patient, and many of those features will fit this patient. The diagnosis of this condition, which is caused by an enzymatic inhibition of a metalloprotease required for the normal functioning of von Willebrand's factor is tempting. However, I was able to review the slide of the peripheral smear with the hematologist, and it showed absolutely no evidence of microangiopathy, the absence of which is inconsistent with thrombotic thrombocytopenic purpura. The other considerations was this disseminated tuberculosis in view of the patient being on infliximab. However, we noted on the liver function test, as we know that tuberculosis is a granulomatous disease, and one would expect an elevation in the alkaline phosphatase and gamma-glutamyl transferase rather than having a transaminitis. A third consideration was this all due to methotrexate toxicity? However, the seizures and the abnormal mental state will not fit in with methotrexate toxicity. I believed at that point that this patient had hemophagocytic lymphohistiocytosis in view of the fact that many of the diagnostic criteria was present in this patient. At that time, I thought the bone marrow aspirate and trephine would be the procedure of choice, as it would explain many of these features. And the bone marrow aspirate and trephine was undertaken, and as you can see in panel A, the patient had a hypercellular marrow with large number of histiocytes with inclusion bodies. Panel B and panel C showed immunohistochemical staining, showing marked number of histiocytes. And panel D, although hemodilute, showed erythrophagocytosis by histiocytes, and the histiocytes contained both mature and degenerate and nucleate red blood cells. And hence the final diagnosis of macrophage activating syndrome secondary to systemic juvenile idiopathic arthritis. Now, we are aware that macrophage activating syndrome has been linked both to systemic juvenile idiopathic arthritis as well as many of the drugs used to treat the condition. In terms of treatment and management of this patient, she was initially started on broad-spectrum antibiotics because of the fever. However, because of the absence of infection, the antibiotics were stopped on day 5. She was given pulse methylprednisolone in the dose of 1 gram daily for 3 doses. However, due to the progressive deterioration in her hematology and her liver function test, suggestive that there was an active cytokine storm ongoing, she was then given intravenous immunoglobulin at the dose of 400 milligrams per kilogram per day for 5 days. In terms of her progress, by 2 weeks, her hemoglobin had returned. Her hemoglobin had returned to 12.5. Her white cell count improved, her platelets improved, and her liver function returned to normal. Her treatment was continued with, infliximab was then changed to etanercept, and the reason I changed the infliximab to etanercept was twofold. Firstly, is that the infliximab therapy was interrupted in this patient for about 3 months, and being antigenic, I thought it prudent that not to expose this patient to infliximab again. And secondly, at the time this patient developed macrophage activating syndrome, there were 2 case reports of macrophage activating syndrome associated with infliximab. However, both those patients were in Crohn's disease. She was also continued on methotrexate and folic acid, and 3 months post-illness, she remained well with a tender joint count of 0 and a swollen joint count of 0. However, on the 31st of January 2012, she presented with marked constitutional symptoms, a fever, and a cough productive of yellowish sputum. She had no joint symptoms at this point in time. She was pyrexial with a temperature of 38.9 degrees. She had signs of a right lower lobe pneumonia, and her joints were quiet. Her chest radiograph showed a right middle and lower lobe consolidation, which was confirmed on the lateral. Her sputum came back positive for acid-fast bacilli, and a diagnosis of pulmonary tuberculosis was made. She responded well to standard tuberculostatic therapy. Her temperature settled, her constitutional symptoms resolved, and she was well. 1 month post-treatment, a repeat chest radiograph shows a resolution of the consolidation. However, she did still have some scarring in the right lower lobe. The problems that we face now is a patient who has tuberculosis on etanercept. The parents are quite adamant that they do not want her going back on etanercept. She's previously had infliximab, and for which it may have been the causative agent for the macrophage activating syndrome, it may not, but how do we proceed further with this patient? And I think I'll stop there. Thank you very much. At the time I saw her, at the current time, she's 23.
23, okay. Yeah. I mean, it's very unusual to get macrophage activation syndrome.
When she had the macrophage activating syndrome, she was 2006. She was about 16.
16, okay. Does anyone have any comments?
Hi. Thank you, Jesh, for that excellent case. You know, with systemic onset juvenile arthritis, that's one of the more difficult types of juvenile arthritis that we have to treat. And macrophage activating syndrome is not uncommon. You know, we've had a few in our clinic as well, and all over the world you'll get that as a reported complication. And one of the clues to it, I mean, obviously there's a high degree of suspicion in those cases, but one of the clues is that when your white cells and your counts start dropping, you know, usually with the inflammatory arthritis, you have high counts. You know, active disease relates to higher white cell, ICRPs and things. The moment these things start dropping, then obviously your differentials, macrophage activating syndromes, infections in our population, and obviously the malignancies. And I think immediately one starts looking at it, and your ferritin and your other investigations, even before the bone marrow, was very, well, reasonably diagnostic, but obviously the bone marrow was important. And in terms of management of these patients, you know, the TNF blockers tend not to work. I think a lot of the studies internationally shows that TNF blockers tend not to work in the systemic onsets, and especially so in our patients whereby TNF and TB is such a big problem. So I think then the new biologic of, well, the biologic of choice in the systemic onset tends to be tocilizumab and the, you know, the IL-6s and sometimes the IL-1s. So I think it's excellent that this patient was diagnosed, treated, and yeah, I think your choices of biologics will certainly not be the TNFs, it will be the IL-6s probably.
All right, thank you. I think we'll leave it at that.
Chinya. The problem is we're having is that they're not registered at the current time for juvenile idiopathic arthritis. So